Merchants Barrage, hailing from Sultanpur, UP, resident of Sai, Mumbai. Khan by community, Muslim by religion, was brought informed by the father with chief complaints of cough and cold since 5 to 6 days, fever since 4 days. The child was apparently all right 6 days back when he had cough, which was dry, non-spasmodic, non-paroxysmal, non-productive, not associated with post-humidity, and cold was in the form of watery nasal discharge, and fever was mild to moderate grade, undocumented, not associated with rashes or chills, intermittent, subsided on local medications and reoccurring after some time. Child was active during the interfebrile period. There was no history of any known allergies or family history of asthma, no history of lethargy or decreased activity, no history of repeated debilitations in past, no history of COX or COX contact, no history of cyanosis. Uh, sorry. There was no history of cyanosis, no history of chills, triggers, and rashes, no history of burning, micturition, and air discharge, uh, no history of decreased urine output, no history of altered sensorium. There was a history of successor cycle and forehead shooting, and there is also history of oil station in ear. Past history of one episode of lower respiratory tract infection at the age of 3 months, for which child received IV medication, IV antibiotics for 10 days, and was on auto support with with mask and not admitted for the same. Taken this medication at village, local village, nobody basis. Some cardiac imaging was done at the time. There was history of multiple episodes of cough cold in the past, which resolved on medication. ANC and birth history. ANC and birth history is not even full. Immunization till date. Development also appropriate for age. Dietary wise, mixed diet. Family history wise, it's the third child, 1 year old. On general examination,
Sir, if this child is 1 year old, can we talk about future two children? Uh, Two more children. Just saying that he has shown five children. Four one has died of newborn hospital syndrome, and then another fifth child. If this child is, we are talking about a 1 year old child. Can we talk about future two children who are not born or following that thing? We, we can talk about the previous two children, but can we talk about future? This child is 1 year old. So आगे के तो बच्चे कब हुए हैं?
नहीं आई आपका वो ऑर्डर का कुछ गड़बड़ हो रहा है। हाँ।
yes,
मतलब अभी ये 1 ईयर का है ना, वो वो जो लास्ट वाला है उसका एज क्या है?
yes. That
ऑर्डर क्या
that
करते
that is the this is the fourth word order actually. Sorry,
हैं? हाँ
the out of order is misplaced.
ठीक बस representing that view.
Yes,
ठीक so now we have a original history of cough, cold and fever. Back. बस flu since 6 days and fever since 4 days in a 1 year old child. So based on these details, what thoughts come to your mind? Out of these three symptoms, which symptom do you think is the most common? What do you think? Yeah, the cough is the most common. We must remember that many times we tend to take cough and cold in one word as a team together. It may not actually be golden. Gold may not be there. We have to be very careful about this, whether we are just assuming it or it is actually a gold. Now, this paper is undocumented, it is mine, and the child is active. So, only we don't know how bad the paper is, but it seems pretty mild and specific, right? And whether it was there or not is also question mark. I mean, whether or not it could be just that. So the main thing is what are your thoughts on it? So if a 1 year old child has come with what, how do you take it for autism? Yeah, very, very easy. Yeah, for every government, you can be also to ask for how to breathing pattern. Now, you will always ask about breathing and all, but you will not off as the means to know. The first question always in any age is that did he have frequent cough in the past? The cough is the chief complaint is the first question. And if they have frequent cough in the past, then it says that this is likely to be reactive already. So the commonest reason for cough at this stage with frequent cough in the past is reactive. Okay. Now, there are many things. One is you have to ask more details about what was there with the cough, breathing difficulty, as you said, whatever. And also, is reactive airway disease of food types or it is just one? So when we talk about reactive airway disease, we say it is atopic and non-atopic. So atopic is what we see most of, 90-95%. But non-atopic is what is this reactive airway disease? This is what could be the reasons? Virus trigger. So virus trigger or immaturity or aspiration or gastroesophageal reflux or congenital heart disease, left to right shunt. These are the other causes of recurrent form of reactive disease, which is not right. And then you have later you give a history of succurrence concept. I think each time we discuss each time we have discussed and each time we have discussed. Then there is a saying of the okay. When you use to say abundantly well. You must realize whether you are really well. The first question is this your first development life? Okay. That's the first question. You can say that for a second one. That reminds you of the you simply know that there is not the normal child or problem. That is number one. Of course, the personal history tells you whether the child has been normal. So, does he be teaching well? Does he be active? Does he be university? Does he play well? Does he behave well? Does he speak well? Are his normal movements all right? His urine is all right? So, many things to us. Any when there is something going wrong, we start asking more questions. Because there's an interesting constipation. Who's there? Who's beginning? So who is constipated since beginning? You start thinking, why is he constipated? So is he an abnormal host? Does he have a large host? Is he hypothermic? I start thinking, and I can understand that. Then what has been discussed so far, this is likely a one topic reacting or viral infection is induced Yeah. Most of the viral infections have fever. If a child is hungry, if the child is malnourished, he will be fever. Maybe go. Most of the time, viral infections settle down by daily they go. If this continues for 6 days, it's not wondering what kind of infection is it. It is not killing the children, so it's not progressive bacterial infection. At the same time, it's not severe high fever. So you start wondering what is the inflammation which is causing the inflammation of the infection is reaction. And then we say, gee, like, these things start coming. Then you are stay 3 months of it. Now, put 3 months of age, maybe get fever comes up. What is yours? What is your take fever for because this time is not exposed to the other members of the organism, you are not within who has several common viral infection, you will get fever. So my first question was given to a fever program for me. It was like, also someone in the field, also. Okay. So there are many I started thinking, oh, this is something unusual. This is an abnormality. Whether it's an human deficiency, whether it's whatever they call it. But really, that really honest, they should have had the feeling that they are getting from some unusual food. How simple that is. Only picture that part. Maybe that any movie is there. This human soul comes to your mind. Doesn't come. It comes only when it's on a master training from what I have data. There is not data for he's in the house. He's only with the mother. The mother is going to support maybe their mission. Should we be known as 2 months of age of small the first question? Now, what's more so? The good question is it already? Is it immune deficiency? Is it specific emotion? Is it maybe problem with the stimuli function like the stimuli dyskinesia or is it cardiac condition with the respiration? Multiple parts and risking at that time when we show very wisely which is the cause of harm. So it's not something. You don't need to get the lesson for this. You need not learn pediatrics for this. You just need to think as a lay person. Okay. Some parents come to us and say, my child, maybe take that exam. Okay. You must also the biggest talking. No, no, no. This question is very but that means you have started thinking what was the cause of failure and the cause was the not studying. This is what is studying by does it understand what is studying? You this very smart. You very smart is studying and you are very studying. Then what is wrong with him? He doesn't have no interest in studying. He has a book. He reads now, but he has no interest. So I filter and this is when I do the question and the answer comes which we think about the next question. Now start asking question. You get the point? You need to do it already at knowledge. I give you an example. In 60 years of my practice, I have never seen a parent coming to me with a child is struggling in a school. After one of the day, whatever is normal, they do it. But then after this, so that's asking question. Doesn't matter. You need to talk. You will be confident in talking. You talk nonsense. Doesn't matter. You will change to sense, but you must talk. you rule out immunodeficiency? Yeah, one more one. Last for repeated skin infection. Okay. If you put it on the last for repeated skin infections, then any severe skin subjects, then repeated episodes of admissions. To be able to thrive overall, immunodeficient child will not grow properly. Right. That is right. Now all this is perfect, but what about the first infection? This is 3 month old. So he's yet to get repeated infection. This is the first. The severity of infection requiring hospitalization, requiring IV antibiotics. Something that requires hospitalization and treatment indicates the severity of infection, either pointing to the host or pointing to the pathogen. It's not a recent effect. It's not a CGD. It's something very serious effect. He said about a combined immune deficiency. He would have had a very severe infection. He could not have come under control quickly. He could have needed hospitalization. And then by then, he has taken possibly the novel polio, or he has taken a BCG. He has taken some live vaccine. We need to ask what was the response to live vaccine. Might give you an idea of whether we are dealing with deficiency. BCG, the reaction may be normal even in an immunodeficient. The polio, for example, so after oral dose, we have diarrhea for 3,000. It's an oral dose, it's an infection. If we could not contain that infection, even if it was a mild virus, pain virus, vaccine virus, I think that is infection. So immune deficiency is let's be consistent. And next is GRD. Yeah. How do you think or rule out GRD? Arching is not there in every child. Okay? If it is there, it helps. But if it is not there in every child, it's not. Then regurgitation. So, normal babies regurgitate. Yes. So, how do you differentiate this normal baby who regurgitate from GR? Only doing well. If you won't be doing well in what way, because it won't be gaining weight, there will be difference. One will do better, fear go away. Anything else? So the normal baby who vomits is called gastroesophageal reflux, which is physiology. And when it is causing problem, you call it disease. So GR. You need to distinction what else. One you said is weight. What else? So aspiration will you pick up in the depending upon the severity, they may present with versus physiologic feeding difficulty, uh, failure to thrive, then recurrent lower respiratory tract infection. So basically, this irritability and kind of reluctance to feed. So they are trying all the time. They're not really wanting because all that is regurgitating, so all that acidic content is coming out. So it makes them feel not wanting to feel. So they have reluctance to feel, which is different from the CNS receivers issue. They are irritable, right? And aspiration is when they bring up and then they cough. So you have a sudden onset of a severe cough, which is related to a bringing of event, then you correlate it and say that this may be aspiration. Okay, so that you think of as GRD. Then what else? Here, cystic fibrosis. Most of the time they present in First year, they present certain GI symptoms more than the respiratory symptoms. So GI symptoms associated with respiratory symptoms. Yeah. What else? When you think of a Rectoesophageal fistula, mainly H-shaped fistula. Okay. So structural abnormalities like H-shaped fistula. Congenital sign of the heart disease. Now come to the heart disease. So you got history of suppressed subtype. So what do you mean by suppressed subcycle? What is the understanding of suppressed subcycle? Now,
Right.
very good. So they need to take rest for some duration while feeding. Now, how will the mother or how will the doctor look at this event? A baby is feeding and is leaving the breast. Can this be also normal? So again, how will you differentiate that this feeding and leaving the breast is not normal, but this is suppressed subcycle? Not lethargy. If it is there, it helps. But if it is not there, the baby wants to feed more but is not able to feed. Even that is basically suppressed subcycle is baby feeds for a moment and then he leaves the breast. Because of he cannot able to feed properly, so he leaves the breast. Then mother again try to feed him by holding him. So that is called as a feeding cycle. The this cycle is baby loosen the grip at the nipple and then again he starts feeding. So typically this suppressive cycle is equal to an older child or adult with dyspnea on exertion. So the sucking is the exertion. The sucking is the exertion. So the baby sucks for a while, then gets breathless, gets tired and breathless. So because the baby gets breathless, the baby leaves. So how do you differentiate that normal baby who leaves just because that baby is looking around who has come, who has gone? That baby is happy, is looking around, and then immediately coming to the breast again. But this baby is breathless and is unable to feed. So it needs a rest for a certain period of time for that breathlessness to settle down so that it can feed again. Right? So that is suppressor. So why I'm trying to get all the details is that when you take the history, if you ask the mother, कि दूध पीते टाइम छोड़ता है क्या? You will get an answer yes. So don't go by that and say that this is suppressed. You have to ask the open question कि जब ये छाती पे दूध पीता है तो कैसे पीता है, क्या होता है? Then if they come and say कि दूध पीता है, थोड़ी देर पीता है, फिर छोड़ देता है, उसको दम लगता है, फिर थोड़ी देर बाद वापस, then you get an idea that this is possibly suppressed. Okay? What does it indicate? Is not the physiological significance. Pulmonary congestion, right? So that is the backflow which is causing this dyspnea on exertion. Okay. Asthma or pneumonia cause that. Usually bronchiolitis can cause. So there is a small difference. So what sir is asking is that suppose as Dr. Sachin said that bronchiolitis is a child baby breathing at 70 breaths a minute. So that baby will also have difficulty in feeding because it is 70 breaths a minute or 80 breaths a minute. So why is it not sucked?
rest, suck in that bronchiolitis breathing? Answer is very simple. I have given you a few words.
The district would really cut it down.
Excellent. So the rest does not bring the 80 to 60 or 40 so that he can suck again.
And suck is also not possible.
Right? So there is no suck only, and then the rest doesn't bring the rate down. So it is not suck, rest suck. So again, parent will tell you दूध नहीं पी सकता है. So don't assume that this is a cardiac thing. You'll have to take a proper history. Okay. Then what is forehead sweating mean? What does it mean? Implication.
Sympathetic.
Why sympathetic forehead? Means why is it happening?
I also sweat on the forehead. Now, it looks like the actually will happen here. Yesterday I was also sweating on my forehead. You know, such one बोलने को पागल
So again, be very clear in your basics. So you said act of feeding is an exertion. So when I climb from the ground floor to the fourth floor, it is an exertion. So if I start sweating, is that the same as this forehead sweating and suppress cycle, or there is something? Very good. It's an unusual activity. That is one. Second, so what is happening here? So suppressed suck, you said, is a sign of pulmonary congestion, which means it is indirectly a sign of left ventricular failure. Okay, cardiac failure incipient. Now, why is in sympathetic activity increased? I'm giving you the clue. What does sympathetic activity do? Increases the heart rate, increases the cardiac output. So body is trying to compensate. Okay, chalo, I'm not able to reach. Let me beat faster. Let me have stronger contractions. So increase sympathetic activity, which also stimulates the sweat glands. And why forehead? Because the sweat glands are maximum on the forehead. Okay, that is why forehead. So this situation may that sweating on the forehead tells you that this is increased sympathetic activity.
When you go up the stairs, 4 stairs, it's exertion. It's not accustomed exertion. I never climbed so much. Not, not sweat. I get breathless. But I don't sweat. You don't sweat. In fact, you start panicking. You do not sweat. In other words, the first response in pediatric age group is an increased heart rate. But in the later childhood or in adult human being, the first response is an increased stroke volume, not cardiac volume. I can increase my cardiac output by increasing my stroke volume without increasing the rate. I don't have to increase the rate. I can increase the stroke volume. If that is not adequate, I will increase the rate. But in children, there is no such compensation possible. Therefore, what we have done, an acute response of the sympathetic system compensation, not compensation. Then that's to investigate that's why we need to quickly get outcome. And that is not possible without the sympathetic system.
Now, you've given history of oil installation. So how does that, how is it connected to this story and what do you think
It's still oil in the nose.
in the year?
Here,
Okay.
you insane in the nose also. Go to south, you will find everybody doing this. Okay. Why is south there to it in west we don't do it? One is culture. But what's the reason behind putting oil when you have a flame? And the reason is you don't have to instill oil. You just to put your little finger in the oil and just near the nasal mucosa required. The reason is you have to have an intruder into the nasal mucosa to react. Maybe allergy, maybe environment, maybe virus, whatever. But that intruder has to be in close contact with the nasal mucosa, which then gets irritated and gets secretions get blocked. Here, a small smear oil prevents contact of an intruder with the nasal mucosa. And my colleagues from South always used to say, if I would sneeze, see, you are not putting oil. I tell you, no, I had so much bad cold this morning. Today I have nothing. You would create a medium between nasal mucosa and an intruder. There is no reaction. And it's not oil installation, it's a smearing that. Same is that oil installation. You know, nose drops, saline nose drops. You don't do that. You just put a drop. Don't do that. Isn't it? Everything in the nose you put, you just put a drop. Whether this one is steroid, put a spray, whether saline drop, put a drop. But oil smear, you don't put a drop. Any reason? When being viscous, the surface tension allows oil drop to go down and cause an oil erosion. But that will not do. So how important is it? So I tell my counterparts inside, you must be seeing oil pneumonia now. They said, yes, we do. I said, we don't. So that is just because of oil. Yeah.
Now, in this child, we have come to the conclusion because of this that this cough is due to a cardiac disease. Now, what kind of a cardiac disease, cyanotic or acyanotic? They have not seen cyanosis. Acyanotic, sure. Correct. So, because there is no sure cyanosis, is it purely acyanotic or you want to say something?
So what question would you ask to separate these two? These two. So potential cyanotic high, which is not visible as against or cyanotic high. One question. And don't forget to ask this question to every cyanotic. And the question is, have you seen a peak of the bluish pains on crying? But everybody who cries needs more oxygen. So we become cyanotic.
Whether infundibular spasm or multiple ways, but it will increase the shunt. Okay, and that is what will bring in a bit of sinus. What is compensated becomes decompensated. Right? Okay. Now suppose this is acyanotic because there is no cyanosis even on crying. And which acyanotic are these? Given this history, what will you think of?
When did the first symptom come? So obviously it's not congenital. It's acquired. Just 2, 3 months were all right. No? Meaning it's not congenital. It's an acquired. Simple, no? How do you counter at my statement is what nonsense are you talking?
So what decides when a congenital heart will become symptomatic? What decides that?
Because I get a head injury. Okay, severe head injury. But just now I'm all right. I compare casualty that you are all right. In the next 6 8 hours, I said I'm getting a sinner and I come into your ICU with unconsciousness. Why does it take time? I had an injury 6 8 hours ago. And at that time you said I'm all right. If I bang my head, and I immediately go to, hey, there is not even a swelling, no, don't worry. Go home. And after half an hour, I come and say, I got a specific swelling. Why the swelling takes time? Why does the brain swelling take 6 8 hours? And why does the corneal class take 2 weeks to manage it? Actually, because the pressure gradient, he knows everything because the difference is by chance here, because this time it didn't lose college. We thought we would meet all of us. That's why he's here. Like, like of course, Hemant and Archana, they come here just to revise and to participate and to keep on learning. But they don't know, we are also doing the same. We also come to revise and learn. So now, anyone. Yeah, because of pressure gradients, change in pulmonary artery pressure takes around 4 weeks to change and completely establish. Understand? Even though initially it is complicated, so it starts to show big signs of decompensation and manifestation and this period of time, 6 to 8 weeks or 8 to 12 weeks. So, little better answer would be that what happens to the fetal circulation as soon as the baby is born? What happens and then what changes and all that? So which ventricle is powerful in the fetus? Right. And which ventricle is powerful afterwards? How does that migration happen? The right is powerful, now left is going to be powerful. So the right must go down, the left must come up. This should take time and only when the left-sided pressure goes down, right-sided, you start getting left to right. There is no left to right. So right-sided pressures fall normally, and left-sided increase. When there is a defect, depending on the size of the defect, because the defect is going to lead to a shunt, the body delays the fall of the right-sided pressure. So in a big shunt, the right-sided pressure takes a little more time to fall. And that is when the shunt gets established, and therefore roughly 4 weeks, 6 weeks, whatever. It depends on two things. One is size of the shunt, and which depends on when the pressure will fall. So this one we were saying 3 months was the first event, which was a pneumonia. It happened within 1.5 months of the pressure falling and the shunt getting established, right? So to that extent, it is congenital still, right? Now we can discuss whether it's shunt or something else, like a valvular disease, myocardial disease, etc. But forget that for a time being. Suppose it is shunt. So shunt at what level? Ventricular, atrial, or ductal? Based on this history. Ductus is out. Ductus would have closed, no? Ductus is out. Can it be PDA? You agree? No, there has to be some reason behind saying yes or no for a PDA. So PDA is more common in what population? Preterm. This was a preterm baby? No, normal baby. No, not preterm. If it's there in preterm, the same fellow goes up to term, no? That is so great. If preterm has a defect, the defect goes down by the time it becomes term. If preterm has, the term also has to have. Preterm may not have. By the time he is coming close to term, he may have. Whoever preterm, always have it at term, no? That's simple. Not any foolish like this. You agree to this, no? You think that 7 months of gestation disappears by 9 months, correct? Not anything. One. What happens to the duct closer to the term? In full term, the doctors know this will recovery into very complete complete refusal, but it takes time. But when it does not grow, the all it will not be development. But mostly by term they easily close. But that's not more common in Britain, but not that term follows very time. So always after a Britain, PhD is the most common. So PDMA basically most common. But PDA most common in pre-term. So probably not, but we keep in mind pre-term have even pre-term. Except for any pre-term. LGS when we say left to right, left to remote, right to remote, when we going across.
So how does ASD present in pediatric area?
Actually, this level is yeah, I had one of our old undergraduate students with an MP study. She was diagnosed with ASD in her second pregnancy. Even the first pregnancy went through because the murmur is not easy to pick up unless somebody ushers this every area. Then she was fine. Suddenly they're going to just X-ray done. Okay. And they found those pulmonary condition. So then we went into yeah, first symptomatic yes. Usually is often first symptomatic. It's different. No?
Yeah, the pressure difference between the atria is not great, so the quantity of shunting is not much. So occasionally it may present in the immediate newborn period as a RV dysfunction, occasionally, otherwise it doesn't present and then straight secondary.
Right? The osteum primary effect. We're talking about osteum secondary effect. That is primary is along with the mitral valve big effect. That may present very time. But that's not common. The common ASD is a secondary effect. That means there is no valve abnormality at all. Never present in childhood, never present in adulthood, maybe small enough. And so that must be ASD.
So that's our provisional diagnosis on history. Now tell us the examination.
Now, are there any other shunts around that way, right? But these are the only two. So when you say mostly ASD, you're past. You want to know how good you are in what fasting. You want to know what was any other next to action. But these are the only three ones. Left side is not only left auricle ventricle, there is also on the left side. On that side, it's not right auricle, right ventricle. Pulmonary arteries are also on the right side. So the other ions of pulmonary connections are also left to right. But they are uncommon. They are syndromic. So one thing we must ask about the milestones in this, right? Many congenital ask about syndromic when they are delayed by milestones. So as a routine, the good student will say, but development is all right. You say, what is development to do with health? So commonly VSDs are associated with syndromes. Yeah, that's correct. Again, we have done this, you're all almost first question. Okay, just learning pediatrics, but no history should be far less than the history of the patient. When such a long no history is given, I could add one more and say no history of any abnormality or a disease in the neighborhood. Okay, why so many? Okay, if there is an altered sensorium, parents will forget it. And I forgot he was unconscious. He was talking only about the problem. So, negative history should be what parents have forgotten to tell them because they thought it was not good. Out of all this, whatever almost is here, have you ever seen bluish film, especially while crying? That's the right thing. Fox or fox contact violence. You think TB is the most common disease in our epidemiology? Viruses are far more common than TB. if you have a habit of asking, oh, history of it is a tuberculosis myocardial disease, but you are asking for a history of contact. No, I don't want to know. At the most, I could say, any illness in the family, yes, if from grandfather, mother, or somebody has TB, you take care of that. That fellow doesn't get TB, but not because of his cardiac problem. So many things out of that. Now, burning micturition. How does a small child present that history, and how does the mother of that small child know that with burning micturition? Difficult, no? So there is medicines as well. I'm just trying to say that a good student is not one who tells lot of negative history. One who tells the least negative history, but more than is the negative history. So take away many of them. Here's the story. Any fool will tell you why here it's flowing. Do not forget it. If you have got a meningitis, तो will get कभी real distance का ड्रामा बार बार होता है अभी नहीं है ये मेरी very disturbing
One.
also
On,
right
yes, on general,
you speak down
you know, on general information, my child was sick looking, irritable, of a male. Heart rate was around 140 per minute. Respiratory rate was around 44 per minute. Saturation in four limbs, 60% in left upper limb, 62% in left lower limb, 70% in right upper limb, and 16% in right lower limb. Not where peripheral buses, central buses were fed. Activities were on. BP in four limbs are 90 by 62 in left upper limb, 70 by 55 right upper limb, 124 by 60 left lower limb, 122 by 74 right lower limb. There was pallor, cyanosis present, clubbing, grade no clubbing was there. No trust,
I think you don't get cirrhosis when you are having severe damage.
uh, lips were yeah, bluish lips. Lip color nail,
You are right. I'm sure you are right. You can allergy present in cyanosis. That means he's above 5, that's all.
Secondly, this is a sick child. So peripheral circulation, if it is poor, then that pallor comes in of vasoconstriction, right? So it looks pale.
skin color,
He must be peripheral also. There.
nails and lips also there. Lips.
Anything else you all notice in the general examination? Anything important you notice? There's any disparity in the BP? What is the disparity? So lower limb BP is reported much higher than the upper limb BP. Systolic BP, there's a big difference, no? Difference of almost 30 mm, and in 30, 40 mm difference. So is that correct, first of all? First thing you need to check is whether it is correct. Is it?
Actually, it was the one not for the upper limb.
Yeah, so because this kind of readings will not be accepted, right? So examiner will suddenly jump on you and say, okay, why this 90 by 762 in left upper limb and left lower limb is 124 by 60. The difference of 34 in the systolic BT not possible, right? So some you need to check on that. Okay. Then clubbing. Okay, fine. Fine. Go on.
Anthropometrically, it was 6.5 kg, which was minus 3 to minus 2 deviation. Height was 74 centimeter, around minus 2 to minus 1 deviation. Middle circumference 11.5 centimeter, minus 2 minus 2 deviation. And his circumference was 42 centimeter, minus 3 to minus 2 standard deviation. Width for head was around minus 3 to minus 2 standard deviation. Impression is minor.
Now you got cyanosis and clubbing on general examination, and on history we discussed a left to right shunt. Now, what is your mental approach to a cyanotic child? Typically, a cyanotic child has reduced pulmonary blood flow, increased pulmonary reduced. And if you have a suppressive cycle, we are talking of increased pulmonary blood flow. So now how will you explain this? Cyanotic means reduced pulmonary blood flow, and we said initially on history increased pulmonary blood flow. Does that tell you something? To increase pulmonary blood flow is for sure because you have that history. So now this tells you that the lesion is likely to be a type where there is actual mixing of the oxygenated and deoxygenated blood. They're probably coming in the same chamber. So they have signs of failure and they have mild cyanosis. That is why on history you did not get cyanosis. Parents did not notice. But on examination you got. This is not deep cyanosis. So this is a situation of failure, mixing of blood. So examples of such lesions are single ventricle, truncus arteriosus, where both the blood come in the same chain, right? So you start thinking on those lines. This has reduced pulmonary blood flow. So broadly, you divide it into two types.